Okay, hi. Hello, everybody. Hope you can hear me. So my name is Winnie, and on behalf of Education Research over at Group Education, welcome everybody to this seminar. We'll be starting pretty soon. Now, this is the second installment in the seminar series, Humanity at the Heart of Healthcare. And this is a series that's brought to you by my team, Education Research. Now, this seminar series aims to highlight issues at the intersections of social science research, the humanities, as well as clinical practice. And we hope that this will be something that's interesting for our clinicians and will give you lessons or something to think about when you go back to your clinical practice. Now, first off, some housekeeping matters. We do have a CME nursing board as well as SPC points registration for this seminar. So this will be collected together with your feedback form at the end of today's seminar. All right, so at the end of the seminar, we will be showing you a QR code for your feedback form. Registration for CME points will be done there. The QR code that you see right now on our welcome slide is for our upcoming session in July. And so if you're interested to hear more, do register using this QR code and we'll keep you on our mailing list. Okay, I think what I'll do now is I'll stop sharing this welcome slide and welcome our speaker and our clinician discussant for this afternoon. So today we have our speaker, and that's Mr. Shaik Amin. Welcome, Amin. Amin is a doctoral researcher over at the Department of Psychology in NTU. And his work, which he will be sharing with us today, focuses on the psycho-socio-emotional as well as spiritual impact of stroke in patients as well as their caregivers. So welcome to Amin. And also with us today, we do have our clinician discussant, and she's Dr. Chan Lai Gwen. Lai Gwen is a senior consultant in the Department of Psychiatry over at Tan Tock Seng. Her clinical and research interests lie in neuropsychiatry, HIV psychiatry, psychiatric issues in traumatic brain injury, as well as stroke. And if I'm not wrong, Lai Gwen, you are well acquainted with Amin's work as well, right? Yeah, I saw your name in his slides at the end where he has his acknowledgements. Yeah, so with that, now that I've introduced our speaker as well as discussant, please, I'll give the time over to Lai Gwen to start us off on the webinar proper. So Lai Gwen, over to you.
Thanks very much, Winnie, and good afternoon to everyone. I'm very heartened to have more than 40, close to 50 human healthcare professionals at a Humanities in Healthcare lunchtime webinar, no less. So while Amin is taking the time to share his slides on his screen, I'd just like to start off with a preamble by saying that I think as healthcare professionals, we are all very familiar with the narrative of stroke patients in the ward, struggling to adjust to their stroke disabilities that are newly acquired, right? Especially in the hospital environment. And in the outpatient setting, we also hear of continued narratives of, continuing to struggle with adjustment, anxieties to recover, anxieties to return to work, anxieties to integrate back with their family. And some do well and some don't, right? And in the extreme cases, some end up in our psychiatry clinic, by which time usually there would have been some family crisis already, right? So some time ago, I was actually very privileged to have been like a co-investigator in a qualitative study that Amin was actually a huge part of, which actually aimed to look at the lived experiences and the psychosocial challenges along the first year after having had a first-time stroke for both the stroke patients as well as their family caregivers. And I think the findings are what he's going to present to us today, as well as some important gleanings from the study, as well as some recommended interventions that may be relevant to our clinical practice, regardless of whether we're practicing in the hospital or in the community. Yep, so it gives me great pleasure to now hand the time over to Amin. Amin, over to you, please.
Thank you so much, Lai Gwen, and thank you so much to Education Research as well for inviting me for this talk. And also thank you to everyone present here, ladies and gentlemen, for taking the time in your busy lunch hour to join me and for me to share what my team hopes to bring to you in our research finding that we have been doing with Tan Tock Seng Hospital and Dr. Chan's team over the past 2 years. So today I'll be presenting the unfamiliar body, understanding non-death losses in first-time stroke survivors and family caregivers. Now, as you know, like when Amin both introduced me, my name is Amin. I am a doctoral researcher in the psychology program, School of Social Sciences, Nanyang Technological University. So to everyone gathered here today, what is a stroke? I mean, that's not something that I would have to define for all of you. All of you are familiar with a stroke. So, stroke is a devastating neurological event that basically affects a patient. And this usually has the two clinical forms. One is the ischemic stroke, which occurs when a blood clot blocks or narrows an artery leading to the brain. And then we have the hemorrhagic stroke, which is, when a blood clot blocks, when a blood clot kind of like bursts, the blood from the artery bursts and begins bleeding into the brain. Now, both these events have significant clinical impact on patients and really causing irreversible damage and changes to the brain. So in 2019, stroke was reported to be the second leading cause of death and the third leading cause of death and disability combined. Now, currently there are more than 100 million people living with a stroke, and more new cases, millions of cases to occur, projections to occur for annual projections. That's what's happening for these stroke incidents. Now, in Singapore, data from past 10 years shows that there is a number of cases of strokes have increased. But interestingly, there's a significant decrease in mortality rates after a stroke. And this simply means that more and more people are living with the disability from a stroke, and their lives are just forever changed. Because what happens now, for all healthcare workers present here, you're most familiar, and stroke survivors and family caregivers are also more familiar with stroke being the loss of physical function, which remains at the forefront of the stroke experience. And this is where stroke rehabilitation has traditionally reserved for addressing these impairments and managing post-stroke disabilities. But the effects of stroke run really deep, and they affect patients in more ways than they can imagine. And these has been reported to have long-term psychological, social, emotional consequences that are basically formed as irrevocable changes to their life situations. So stroke survivors talk about the loss of autonomy or control that they have in their lives, the loss of normalcy, in terms of their daily routines, the loss of relationships and roles with their loved ones, and the loss of identities. And these effects have been shown in the recent literature to impede physical recovery and negatively influence their quality of life and social functions. So stroke survivors are not the only ones affected by a stroke, and we all know that family caregivers are affected as well. So family caregivers are those that assist stroke survivors with their self-care and rehabilitation, and they usually report being severely unprepared for the role and that sudden transition into that caregiving name tag, for example. And this causes them to experience disruptions that are very similar to survivors, in addition to the feelings of caregiving burden. And caregiving difficulties have been widely reported to not be the focus of current healthcare systems, because caring for the patient is a huge job in itself. And at the same time, a very interesting paper that I read earlier this week is that the experience between a dementia caregiver and a stroke caregiver, there was shown to be no difference, meaning to say that the stress and the burden levels are equal and almost the same. So it's a universal experience. So what happens to stroke survivors and family caregivers? And to give this a deeper understanding of their psycho-socio-emotional and spiritual impact, I will use two theoretical perspectives. The first one will be the assumptive world perspective. So the assumptive world perspective talks about this complete shattering of one's core assumptions, like this picture you see here. Now, that is the things that make you feel safe and secure and give you meaning and purpose to your life. And when this shattering happens to what we regard as safe, stroke survivors and family caregivers experience multiple non-death losses. Now, non-death losses are losses that don't need the experience of death, but you still feel grief and sadness for things that they can't have anymore. Now, these can be losses in identity, in notions of self, losses of roles, losses of autonomy, relationships, and normalcy. Now, to give you a deeper impact, my team, we conducted two unique systematic reviews, qualitative systematic reviews that synthesize the experience of loss and recovery in the wide literature. So for the experience of survivors, we developed and proposed the psychosocial rehabilitation trajectory of stroke survivors model, which is the first known review that analyzes qualitative systematic reviews to give an understanding of what a stroke survivor's losses are and what are their recovery needs. So the assumptive world perspective says that stroke survivors experience multiple losses that make them feel like a body that's no longer familiar. Now, to give you context to what this means, and I'm using these terms quite interchangeably. Now, my father was a stroke survivor, and when the stroke hit him, he had his unique symptom was that he had word-finding difficulties. So in that is the physical dysfunction, and he goes through physical like speech therapy, right? But what happens is that actually broke his identity. And it broke his identity because he was a person who likes to talk, and his words have meaning, spiritual advice. All of these things are some things that he cannot do anymore, and he struggles to do them. So that is what they feel, that my body is no longer familiar, my world and what I know is shattered. Right? So that's the experience of my father, to give all of you some perspective. So they rebuilt this assumptive world by actually reconstructing. Human beings cannot just sit down and suffer. They actually learn to cope, adapt, and manage the stroke in their lives. And this model shows that it's not just drawing intrapersonal strength themselves, but having a healthcare system that's compassionate, having rehabilitation practices that are holistic, and other agencies like in their relationships for them to thrive forward and come out of the stroke as new formed individuals. Now, for family caregivers, they also experience losses and also have coping mechanisms. So the living losses in stroke caregiving model talks about the shattered assumptive world perspective as the loss of identity and relationship with stroke survivors and the emotional distress that they have from the sense of isolation. So in the story of my father, I, as a son, suddenly I had to become a breadwinner in the family because he cannot work. And I miss my dad because he is a person who was my Superman. And when your Superman is unable to talk to you and give you advice like how you used to receive it, that shatters your assumptive worlds. And that what is no longer, what you thought the world was safe is no longer the same again. So how caregivers rebuild their assumptive worlds is that they ascribe new meaning to their post-stroke experiences and relationships, and they reinterpret what caregiving actually means to them. So with all that said and done in the current literature, we talk about some of the research gaps and what are some of the things that we need to look into for further research. So currently, there are no interventions that specifically address post-stroke losses, right? This is a huge point of emotional grief and pain for many individuals. And there are, and when you create these interventions, they need to be culture specific. Now, when we talk about culture specific, the data that we've analyzed in the two systematic reviews showed that most of it was founded on Western context. So in order for us to understand what we can do for the Asian population, we will need to understand what are the losses and recovery needs in the Asian population. So we did just that. So the current study was, the first aim was to examine the Asian experience of post-stroke loss, uncover the nuances that influence coping strategies. What is it? How are we coping that's so different from the world? And from there, understand the needs for recovery and the needs for caregiving so that we can develop a model. So we drew data from a longitudinal study, as Lai Wen mentioned earlier, and survivor caregiver diets were recruited from Tan Tock Seng Hospital and St. Luke's Hospital using this inclusion criteria. So they have to have a mild to moderate stroke, first time mild to moderate stroke. They must have an active primary caregiver, discharged from in-person care no longer than 3 months, because we we did not want to go to patients where they are just discharged and just reeling from the experience. So that's this inclusion criteria's underlying reason. Cognitively stable using the MMSE, able to communicate and of legal age. Those who were too sick to participate or cognitively unstable were excluded from the study. So 30 diets were recruited for data saturation. This is a primarily qualitative study. And for the current analysis, we present a portion of the collected data of 11 diets, a total of 22 participants. Now, for this research, our analysis will show you the acute, subacute stages of stroke. And for the methods, we have used in-depth interviews to understand the survivors and family caregivers' individual and shared experiences. And the interview guide looks something like this. So we ask them, how was life before the stroke? What changed after the stroke? What motivates you to move forward? How has the healthcare team helped you? What are some of the losses you experienced? And how are some of the inner strengths and coping strategies that you are employing at the moment? So we use the qualitative data analysis method called the interpretive phenomenological analysis, which is very important especially in stroke survivors and family caregivers or families experiencing a trauma, to understand how they create experience, how they create meaning from the experience of that phenomenon, so the insider perspective. So our research, we maintained for qualitative research credibility, which means the accuracy of our results. We maintain transferability so that we can apply it to other Asian contexts, and also the conformability, how objective we are in the research data. And we use this through inter-researcher consensus, peer debriefing, having descriptions of context, having a triangulation. What does this person say? What does it mean? What is the depth of the sharing? And also researcher reflexivity. What are some of the things that we uncovered, how we discuss, how we can improve ourselves and build upon our experiences in following interviews. So a total of 11 diets. As you can see, that most of the patients were male. They were more older than their family members, and most of the relationships were spousal relationships as well. So the research process allowed us to develop the family coping model at stroke. And so basically we had 22 teams, and they were categorized into 6 sub-teams, starting with the unfamiliar body, which is the patient experience of loss, and then the prioritizing recovery, which is the patient's individual coping strategy, the unprepared surrogate, which is the caregiver's experiencing of loss, the cultivating resilience, which is the caregiver's coping strategy, and then the re-establishing partnership category talks about what they do together as a family. And all of this is happening under their needs of what they think they need from a compassionate healthcare. So the unfamiliar body talks about the disrupted regularity in a sub-team that talks about the disruptions that they feel to everyday life. So this patient says that last time I never asked my family for help, I could just go down and buy things for myself. Now I cannot do that anymore. Now, fractured sense of well-being describes how stroke survivors experience this general sense of reduced well-being from the effects of stroke. As a stroke patient, you start thinking of what you're going to lose, more like your vision, your speech, your hearing. You just don't know, these feelings of uncertainty. Crippled self-image talks about the changes in self-identity and that, those negative self-evaluations that they live with after the stroke. This patient talks about being, after the stroke, I became my wife's dog. Now, individually, stroke survivors make sense of the stroke experience. So what they do is that they reorient their life view. They talk about the stroke being, it's a blessing in disguise. You have to be positive. God is teaching me to be a better person. Stroke survivors talk about this empowering support, where they draw support from their social networks. My wife keeps encouraging me to be more positive. She tells me I don't have to worry. When I hear those words, I feel comforted. And then stroke survivors do their best to get back their physical restoration. So they're intrinsically motivated for that. They focus on that. I have to work hard on my own recovery. I schedule all my exercises myself. Stroke survivors talk about exercising introspection, like talking about where we went wrong and what can I change after the stroke. So if I had the stroke, if I had to work, I would stay overnight to finish it. But I guess that is not the way it should be anymore. And stroke survivors have this underlying sense of need to recover because they want to honor their familial responsibility. So one of them, this patient said that one of the main reasons I push myself is because I have 2 kids and an elderly mother. They are the ones who give me the courage to go on. Family caregivers the unprepared surrogate, they experience this obscured familiarity, which is this uncertainty and loss of control from the stroke. So this caregiver says that if he can't stand up, how can I bring him home? Once he is home, what will I do? What will happen to my children, his mother? I have no answers to these problems. Then family caregivers talk about feeling helpless in their situations. They feel that whatever they provide for survivors is just not enough. I can understand that he's going through something that he cannot express. Depression, maybe, I cannot tell because he does not experience himself, and I feel like I can't do anything. Stroke caregivers also talk about this loss of mutuality with stroke survivors and the dynamic of the relationship being changed. This caregiver talks about, my mother insists on doing things on her own despite us telling her not to. It takes a lot of telling to get through to her, and that causes a bit of strain. Stroke caregivers then rise to the occasion by cultivating resilience, and they do that by simply being there for stroke survivors in this sense of familial duty. In my house, there's only me, my husband, and my son. So if anything happens to me, I just step in and do what I can as a wife and a mother. Stroke caregivers also talk about embracing optimism, reframing the situation, looking at positive silver linings. So they'll say that I would say that his condition is manageable. Thank God it's not worse. I believe that this phase is only temporary and that we will overcome it and move on. Stroke caregivers also talk about projecting strength. They regulate their own emotions by deliberately concealing these worries. I encourage myself to keep going, knowing that if I give up, this family will fall apart. Stroke caregivers also talk about finding some support from their social networks. My daughter and me talk and support each other. My extended family caregivers make me feel supported as well. Now, stroke caregivers do this last thing by counting their blessings. So they find this thing that this stroke happened because it's a chance for them to reconnect with survivors and care for them with love and dedication. Frankly, I'm very tired. I need to manage several things, but I think that he's a blessing to me. Without him, I wouldn't know what to do with my life. So stroke survivors and family caregivers talk about this doing things together. And the first thing that they do is that they practice reciprocity. What they do is that they work together to manage these feelings of burden. This caregiver says that he's a blessing to me and I want to motivate him. And when he doesn't give up, it helps me help him get back to his previous self. And this patient says that needing to take care of me on top of what needs to do is burdensome. So I just want to tell them, thank you. Now, stroke caregivers also talk about managing this health vulnerability. Now, they don't want a ill health or negative health event to happen again. So this patient talks about, I don't smoke anymore, I watch my diet, I exercise every day. And this caregiver talks about, I remind him to not be greedy and encourage him to watch his diet. And then they visualize normalcy. They want a future to be functionally independent and get back to doing their normal routines. This caregiver says, I want to see him get better so that we can live our lives normally like before. And this patient says that I choose to wake up. I choose to recover so that I can go back to driving for my family and get my life back. So stroke survivors communicated a lot of their needs of what they want from a compassionate healthcare. So recognizing holistic potential talks about how survivors says that I wish that there could be a counselor to help me look at the positive side of things because they felt that they do need help with their emotional and mental states. Family caregivers talk about needing additional support to let them understand what to expect when they go back home. Fostering collaborative environments talk about how stroke survivors would like to feel that they don't know what to look out for, that the therapists are the ones who are the experts, and they would like to feel that they will have some ways to assume responsibility in their recovery, but they are lost in that section. A family caregiver says that I believe that we only can do so much and it cannot be as good as therapists, and they feel that they need that extra help to get out and be agents of their own recovery. Now, humanizing hospital care talks about stroke survivors and some of the experiences in the hospital. One of these patients talks about, I wanted to get out of the hospital because I understand of the manpower issues. I was soaked in my own soil for hours. And this family caregiver says that, I would like the hospital staff to basically understand, because she said they insisted that I should have a sole caregiver. And despite me telling that my family had a plan, they even asked me to consider sending my mom to a nursing home. And they feel that this could be treated with better respect and empathy in their decisions as a family. So in the discussion of these results, we understand the stroke survivors are their experience is that there's a strong sense of familial duty. So recovery motivations are usually to resume familial duties or reduce burden of family caregivers, and that's where they're usually coming from after the stroke. But they express needs that they want holistic support to process the psychosocial impact of stroke. Family caregivers talk about the experience of stroke as a compassionate duty, which is also very, very reflective of the Confucius heritage thinking, or the notions of filial piety and filial compassion that is the structural forces that are governing our societies, especially in Asia. And their needs, but they do have needs, and these needs are that they want more emotional, informational forms of support. So the dyadic experience of the stroke is that we understand a lot of this mutuality is very pragmatic and practical issues, which is a cultural norm. And there's very little emotion-based coping, and the needs that they express is that there is a need to enhance that dyadic coping so that they could rebuild these assumptive worlds and not just focus on how they can just live their lives on a day-to-day basis and manage the effects of stroke. So like the process of kintsugi, if you are familiar in the Japanese art of putting together broken pottery with dignifying goals, the piecing together of assumptive worlds basically it's an idea that stroke survivors and family caregivers have the ability to put together these broken shards and from there rise above these post-stroke challenges more stronger and more resilient as really living their lives as beautiful works of art. And in order to do that, they do need that support, and that calls for the development of a multi-component strength-based dyadic interventions that our research has shown to actually promote in the rebuilding of these assumptive worlds, so that we can firstly comfort these families, educate them, encourage them, and inspire them to actually think of themselves as beautiful works of art. So how do we do that? So we talked about intervention design, and when we talk about doing this intervention multi-component, the first thing we want to do is education. So psychoeducation talks about providing this illness-specific information and these tools for managing these related circumstances. And then we talk about dignity enhancement. So dignity enhancement is where you get the dyads to talk about themselves. So dignity enhancement has seen a lot of work in the palliative care settings, and I'm sure that if our PalMed friends are here, they could talk about this as well. And basically, it's about building. But however, the only difference between the death about dying and a stroke is that the losses are almost the losses are the same, but that the person who is in end of life dies, but a person with stroke has to continue their living of self. So the adaptation of dignity enhancement into stroke care is severely important because they need to continue living and they need to have their dignity enhanced so that they can move forward with their dyads as a family together. And the last part is self-compassion. Self-compassion talks about this idea that you care for yourself as much as how you would care for another person. And this involves three things. First is self-kindness, being kind to your own self, soothing your own self, telling it's okay, understanding of common humanity, that this is an experience that is, you're not isolated in this experience, and this idea of mindfulness, where you are in pain, and you feel the suffering, but you know that this is a suffering that you can get through, that you don't, like they say, don't stab yourself with a second arrow. You look to heal yourself from that particular session of suffering. So we put all of that together and we propose the development of the aspirational rehabilitation coaching for holistic health. In short, we call it 𝗟ci. Now, 𝗟ci is a 4-week intervention, and we are happy to announce that recently we have received funding from the Enabling Lives Initiative grant for the development and testing of this holistic intervention. So 𝗟ci is a 4-week intervention that starts with week 1, where we want to soothe the loss of families experiencing after a stroke. So this means that you want to get them to harmonize with the post-stroke losses and normalize their grief and give them that comfort after the stroke. Now, week 2, we talk about embracing impermanence, meaning to say that we want them to see hopefulness in recovery and learning to focus on gains and not losses. Week 3 is about empowering their daily living, meaning to say that, you give them alternative methods to face these living challenges and contend with losses. And the week 4 is basically we want them to foster mutuality, which talks about them recognizing the need for a mutual beneficial relationship to grow and move together from the stroke. So the ARCH program each week presents 3 main activities. So the first week has an education activity where patients and family caregivers will receive a brief overview of what is post-stroke loss. And then from there, understanding what is self-compassion and how does self-compassion help me in alleviating my current form of suffering. And then from there, we will do the dignity enhancement activity, which is the communication activity, getting the dyads to talk about and acknowledge these losses. Now, for example, in one of the sharings about our patient, this patient, she talks about another patient who says that he has the post-stroke fatigue and the post-stroke tiredness and the post-stroke speech difficulty and the slurring, and the person's wife had no idea of these things, and he feels that he shouldn't tell his wife because it's just a form of weakness. And this is a very prevalent idea in this in the Asian community. So this is one of the ways that we want to get them to acknowledge the losses that have transpired from stroke. And then we want them to do a self-compassion practice, which means working with difficult emotions. So there's a lot of emotions that comes up after stroke, and there's a lot of pain attached to the suffering. And we want them to allow to experience that, look at that pain, soften that pain, and then allow it to coexist in their being and help teach them. This practice is not just a one-off thing, but teach them how they can work with difficult emotions as this experience of stroke continues. Now, embracing impermanence, talk about the education activity that we want to do is about helping them to understand the transient adaptations to adversity. So we want to tell them about resilience, about forgiveness, about forgiving themselves, about being resilient, about being strong and having courage to face the challenges of stroke. And then the dignity building activity gets them to actually identify these strengths within their dyad and see how have we coped with these difficulties before and what can we do now. Get them to have the conversation really early. And then we talk about the self-compassion practice, which is the autobiographic timeline, which is an activity that gets them to look at their life. It's similar to a life review that tells them what are some of the areas where you had the peaks of your life and where were some of the times you had the downs and how did you cope with the downs, to get them to remember those things that they would have forgotten based on their current experience of suffering. And then we talk about empowering daily living. So we want to get them to start relating these disruptions to goal setting. So, we understand that this idea of coaching, where health coaches are always talking about health coaching, and they're always talking about, motivational interviewing to get them to meet goals. So in this session, we talk about them making goals. What are the importance of setting goals that are important to them, that are meaningful to them, that is different from what the healthcare institutions talk about? What are some of the physical things that they should be reaching or ability to do? This is about their life and what they would like to do. And getting them to talk about how we can co-construct these solutions. What are some of the things that we can do? For example, we use the idea of solution-focused healing for self-compassion. So we will tell them, we ask them questions like, okay, imagine a miracle happens to you right now, tonight when you're sleeping. What will it be? And it changes one of the things from the stroke, what would it be and how would it change your life? And from there, get them to build that feeling of what can happen and what they would like to achieve in their recovery. And the last part, we talk about fostering mutuality, which is getting the dyads to work together. So understanding that they are giving them education, saying that it's okay to cope alone. We all need to do that, but we also need to cope together as a family, as a dyad. And want to tell them the benefits of that, and then getting them to talk about it and saying that, what are their needs that they have individually, and what are these shared coping styles that they can adopt and build together in this family, in their family unit. And from there, they want to give this idea of self-compassion, which is giving and receiving compassion, which is a compassion practice where we tell them to imagine a person that comes to mind, a person that they love that comes to mind, and then how how will they give that feelings of love to that person? What are some of the feelings of love that they want to give to that person, and get them to get used to that imagery and feel that safe space in their familial settings. So before I end my talk, I would like to leave you with this quote. Maybe you're not healing because you're just trying to be who you are and who you were before the trauma. You know, that person does not exist anymore because there's a new you that is trying to be born. Breathe life into that person, right? And with that, this is my team. So for this research, as I mentioned earlier in the research, in the slide that, you know, we have received funding from the grant to run and test this study. So potential teams who would like to work with us, please get our contact details that are on the screen below, or please reach out to 𝗨𝗀𝗄𝗏, our wonderful 𝗙cie his𝗀𝗃𝗁𝗏, and we can all have a meeting and discuss and how we can work together. So thank you so much for listening.
Great, thank you so much. I mean, I really enjoyed your presentation because I think it articulates a lot of observations that we have had for a long time. But as healthcare professionals who are very busy trying to fight fires in healthcare to do with physical health and medical health, very often we don't have the time to sit down and reflect and actually try and articulate these experiences for ourselves, for our patients, and also for our caregivers. So right now is actually question and answer time, and I would like to invite our attendees to actually type your questions into the Q&A box, where we will try and address them all when we have the time. But I mean, maybe right now I'll just ask you one question that has already been typed into the chat box since 1:31 p.m. And someone had asked that he or she is curious about the ethnicity of the participants, as you have associated compassionate duty to Confucian values. And were there only Chinese who talk about this?
Thank you so much for that question. So, you know, my supervisor, Prof. Andy Ho, he has a wonderful answer for this question. I'll just try my best to relate this question. The Confucian values of filial piety, yes, we actually have a mix of participants, but they were predominantly Chinese. However, when, you know, the patients who were Malay and also the Indian patients, there was a very similar connotation, a very similar underlying belief system when they actually answered, when they actually talked about why they should serve their family members after the stroke, and how they should care for their family members and why they should get back. And you know, the underlying understanding is that the Confucian values of filial piety, they're universally stretching into the Asian value system. And now it has translated over the years and years of how much of it is deeply rooted in the systems of every ethnic belief, and that, you know, serving the family member, which is like, it used to be just serving the parent, but it also extends to serving the husband, serving the wife, serving the children, and doing this for the family. So it is all encompassing. That's what we would like to say.
Okay,
thank you so
maybe
much.
I can just add on to that question and ask whether, you know, from your systematic review, is this aspect of familial duty or filial piety, is that much different from Western literature?
Yes, it is very much different. So the Western literature is a very individualistic culture, and that's the nuances that we got from the base. So there's a lot of experiences. Like, for example, the family caregivers, they talk a lot about, you know, like, I'm doing this, and then they say that, you know, like, this is just something that I do, and it may not even be something that I want to do. And this is a very strong notion, like, I make this choice, I make this turning point choice to help this person. And that's what a lot of it says. But in our context, in the research that shows, is like, like, you know, and I look at the transcripts, the first thing that they say is, I don't know why you're asking me this question. I just do that. This is my job. I'm a family member. You know, that's the main response that we get.
Okay, great. Thanks very much for your answer. Yeah, so while other people are typing in their questions, I do have a question or two of my own. And I think one observation that I made from your talk, right, was about these two aspects of being able to practice reciprocity and also the sense of familial duty and of not being a burden to, reducing the burden to their family members, right? And actually, in our experience, actually, the two actually seem to run quite counter to each other. So to demonstrate what I mean, right? So over the weekend, I was at ICA collecting passport for my daughter, and I came across an elderly couple, husband and wife, who were there to collect passport for the wheelchair-bound husband, you know, who was quite clearly to me was a chronic stroke patient. So as I was assisting them, because there are many steps to go through and all that. So as I was assisting them, the wife was actually sharing with me and complaining to me all the time that she says, oh, they're only here because the son wanted to bring them on a cruise, and this will be the last time ever, and it's too troublesome to bring him out anywhere, and she will never ever, you know, bring him out anymore. And, you know, she thinks it's better to just keep him at home all the time henceforth, and, you know, that kind of thing. So actually it's quite counter-cultural for us in our culture to actually reciprocate, right, these gestures of kindness from our family members, right? And that's quite in alignment with how we seem to practice our familial duty in reducing that sense of burden for our family members. And I just wonder what comments you have to say about that.
Yes, I completely agree with you. Like, when I think that, you know, it's a very deeply rooted issue in the you know, it's not, I wouldn't say it's an issue, it's a very deeply rooted kind of a thinking that has in all our patients, and they always talk about this idea that, you know, I just don't want to be a burden, I'm troubling people, and that's what you say. Troubling people is a very Asian value. It's very, like, if you look at the Western literature, you do not, feeling like a burden is very common, but troubling people, and I don't want to make their lives difficult, it is expressed very differently in the Western context and very differently in the Asian context. And it is a notion of, it is a source of tremendous stress for the Asian participants as well. And then, you know, there's this one diet, right? The dad is saying, like, you know, I think there's this very colloquial Chinese saying, like, you know, thank you, a certain way of saying thank you for the service that you do for me. And then, you know, the daughter gets very upset, and a lot of caregivers get very upset. They're like, why are you telling me thank you? You know, no, because I've made your life difficult. And then they're like, no, but why are you, but stop saying it. You saying thank you to me is hurting me. You know, it's a very inverse relationship, right? So we want to talk about, like, so the reciprocity, I think the intervention, when we put it into that, and what we are trying to build with these patients is that they should feel okay to say thank you. They should feel okay to address their burden in open with their family members, and they should be able to grow from that experience. And it should be a source of strength rather than a source of stress. So building the idea of gratitude into the recovery journey is what the intervention does, and that's what self-compassion does. I am grateful for your help, and we're turning that narrative around, which is the heart of the stroke humanities, hopefully. Thank you so much for that question.
Great, thank you so much. I think we can address some of the other questions in the chat box. So someone has said here, I see similarities in what you are doing with sense-making in crisis. And if you are comfortable, could you comment on the role of sense-making and whether these interventions are aligned with the normalization process theory?
Thank you so much for that question. So yes, I would say that, you know, the role of sense-making is extremely important, and it is the idea of meaning reconstruction that we talk about in the intervention and how we hope to get them to process. So the idea of meaning reconstruction is also in the palliative medication journals and research, you know, the end of life studies, where they talk about sense making when something bad, when the death happens, and how they try to make sense of the death, and how they try to have those bonds to continue after the person has passed. And also this idea of looking at the silver linings. And this is so apparent in stroke survivors because we are really bringing the idea of reconstruction to these ideas that you know, that the kintsugi, that bowl that I showed you, that's the sense making. Basically, this has happened to me, and all this, I feel so broken, like my father, right? I can't speak anymore. How can I reconstruct myself? And what can I do now? You know, or how can I re-identify myself in the family, which is also part of what sense making truly is. And at the same time, stroke survivors like to do this very silver lining thing where they say that the stroke that hit me, because this is all first time stroke, mild to moderate, right, is not so severe. Thank God it's not so severe. And so these two major processes of meaning reconstruction, which is very also embedded within the normalization process theory as well, it is what we would like to bring about as the major part of stroke psychosocial rehabilitation. Thank you so much.
Thank you so much. Yeah. Okay, I think we have one other question, and there's a bundle of 3 questions to do with the 𝗟ci intervention, which we will address later, but let's address this one first. And somebody has asked whether you have heard responses about encounters and coping with crisis, for example, medical complications, depression, burnout during stroke care, and what has been helpful for this?
To clarify for this question, like from the patient's point of view, coping with crisis, depression, burnout.
I think it's probably for both the patient and the caregiver.
Yes. Yeah. No. So I think that, you know, we are looking at these patients from the first time stroke, and perhaps due to the nature of the stroke being mild to moderate, the idea of depression, burnout, it does happen. Burnout does happen. Depression and burnout are, I mean, we cannot diagnose depression and we can't say whether it's clinical, but we do see signs of burnout and depression in the stroke care, in the family caregivers, when we start to see them in T3 and T4. So T3 is, I would say, sorry, T3 is 9 months after the stroke, and T4 is a year after the stroke, and that's when you see the faces cracking and the realities getting hit. And I can't because, you know, we're currently looking at the subacute and acute stages, but in the longitudinal analysis, I have one particular caregiver who talks a lot about, oh, pain, I'm getting depressed, I want to leave my husband, I want to divorce him. And these are things that I can't, and it just pops up a lot. So it's in the much later stages. So thank you for that question.
Okay, great, thanks. So right now we have a bundle of 3 questions, all to do with the 𝗟ci intervention. I think one practical question is that someone says she has a client, or he or she has a client and her caregiver who would benefit from joining this, and what's the criteria for enrollment, and whether the intervention would be done in Chinese as well. And also related to that, whether you would potentially be opening up the 𝗟ci intervention to non-stroke patients who have similar psychosocial trajectories. And also, when is the presentation on the program evaluation due?
Okay, everyone. We just won the grant. We are in that high right now that we won the grant. So, but thank you so much for that. And I think that, you know, I'm actually really happy to see that the amount of work, that the amount of response that you're giving to 𝗟ci, because so to answer your question, 𝗟ci is basically starting around July, hopefully. We are currently in the stages of submitting the IRB and all that. And we are sincerely recruiting only still the same first-time stroke survivors and family caregivers. And we, sorry, the patient that you mentioned that she has a disability, is it?
So one question didn't specify. Just wanted to ask whether it will be administered in Chinese. And another question was for a client who is non-stroke.
Non-stroke, yes. So for non-stroke, not off yet. but we would hope to extend this to hopefully non-stroke and other neurological diseases. And I think, hopefully even come up with a series of training for the healthcare providers to actually administer 𝗏. And we have a lot of exciting things coming your way. So stay tuned for our teams and what are we going to bring to stroke care. And at the same time, yes, we have translated the intervention to be administered in Mandarin. So that will be coming your way as well. So look forward to it. Thank you.
Great. So just to clarify, the pilot trial, that will be administered in both English and Mandarin, is that correct?
Yes, that's right.
Okay. And you'll be recruiting from the same two sites, Tan Tock Seng and St. Luke's?
Yes, that's right.
Okay, so maybe just look out for the recruitment from these two sites.
Yes. Thank you.
Okay, yeah. I think we just really have about a couple of minutes left. So maybe I can just come in here with a couple of my own questions. So maybe just to wrap up, for healthcare professionals, from the interviews that you've had, what would you say is the one most common thing that you've heard from the interviews that patients felt and patients and caregivers felt was most lacking in the healthcare that is currently being provided? Amin, are you okay?
Sorry, can you just repeat that again? I lost you for.
You lost me, okay, yeah.
Sorry.
So based on the interviews that you've heard, right? So what would you say is the one most common thing that patients and caregivers felt was most lacking in the current healthcare that is provided? Okay,
got that now. The main one is when they are in the wards, they are feeling very difficult. The difficulties that they raised was the manpower issues in the ward settings. And this has been a data saturation, as I shared earlier, at least about 10 accounts out of the 11 accounts that I shared, talking a lot about the difficulties of how they're needing support from the healthcare team, from the hospital nurses, but they're not getting that, and that makes them very upset. And then they feel that is the experience that gets them to not want to be at the hospitals. But they also say that, we understand they are busy, we understand that it's difficult and there's not many people around, but we really wish that, if the second stroke were to hit us, that's the one thing that I don't want to go back to. So it is the main experience.
Yeah, and that's kind of like a huge
worldwide
struggle
issue.
And charity. Yeah, so it's a worldwide issue, right?
It's a worldwide issue, yes.
Yeah.
Because so we can empathize with them. Like, we hear them, we understand, we feel you, but then, but one thing good about the stroke thing is, I hope our rehab colleagues are here. They love the rehabilitation program and they love the physiotherapists. And there's a lot of big shout outs to the physiotherapists and the occupational therapists for really making them feel like their recovery, there's power to it and they can do it and they feel the energy. They want more, and they want the hospital to please engage us more so that we can do it when we are discharged. And sometimes they are lost in that transitional process as well. But they feel that they just need more, and when they do receive it in the hospitals, they love it.
Right. Okay. So at least it's nice to hear some bouquets and kudos to what we're currently doing. Okay. So so based on your learnings from this study, right? When do you think actually is the best time to start our work with the caregivers?
So as I mentioned earlier, I think the caregivers, they have the difficulties. In the early stages, they don't feel it. So I would say 6 months, 6 to 9 months after the stroke is the best time to go look at the caregivers, because that's when it starts to set in, the mask fall off, and that's when they start to actually really feel the pressure of caregiving. And that is when they will really express the most strongest emotion. In the early stages, they are just trying to deal with the whole situation.
Right. Okay. So if anything, if we're looking at preventive work, it should start even earlier than that, isn't it?
So preventive work is why 𝗏ci is coming in right at the subacute stages, because we want to give them the tools and the ability. So psychoeducation, right? The soothing and the tools.
Okay.
So when this happens later in the stages, you know what to do and you can do something for yourself. Yeah.
Okay. Great, thanks so much. And I think it's the right time to wrap up our webinar this afternoon. I think we've all had a very, very fruitful time together. Thank you so much once again to Amin for your very enlightening talk. And I think at this point, I'll hand the time back over to Winnie for some housekeeping matters.
All right. Okay, thank you so much to Amin as well as to Lai Gwen for hosting the talk. Amin, thanks so much for sharing with us your work. And I sense that, there's been quite a lot of interest, not just from just stroke patients, but also, for various parts of rehab as well. And we hope that this seminar will actually pave the way for further conversations about 𝗟ci and how this intervention could possibly be disseminated and benefit other patients. Yeah, so thank you both very much. Maybe I could have the housekeeping slide. Yeah, so thank you very much to our speaker, to our discussant, to all our participants as well. Thank you so much for staying with us, and I hope you had a fruitful time today. We'd like to hear your feedback. So if you look at the slide that we have here for you, the top one gives you the feedback form as well as the registration for your CME and SNB points and so on. So please use that brown QR code at the top for that, for CME points. We do have an upcoming seminar. So that's the third one in this series. It's about mindful, compassion-based art therapy for HCP or healthcare professional burnout. And it's given by Prof. Andy Ho from NTU, moderated by Dr. 𝗪𝗏, who is from PALMED in Tan Tock Seng, and also presently, I believe he's the medical director at 𝗨𝗶𝗹𝗆. So if you're interested, do point your camera over at the second QR code, register your names for the next session. Okay, so thank you all very much. This webinar was also made possible by our special events team. So thank you for helping Edu Research for hosting this seminar. So for our participants, thank you very much. Do feel free to exit the session once you filled up the feedback form and registered for your CME points. Yeah, thank you very much.